Honorable panelists of this session, honorable audience, good evening to everybody. My topic is management of pseudoexfoliation glaucoma. I don't have any financial interest. I'm Dr. Shams Mohammed Noman, Associate Professor, Department of Glaucoma, Bangabandhu Sheikh Mujib Medical University, Bangladesh. I want to start with a case. This is a case of male, 51 years. He had a vision 660, pinhole 612. He has a 35 millimeter of mercury with all medications. In picture, we can see some pseudoexfoliation materials over the lens. This is the disc finding, advanced cupping with bipolar notch. I did the trabeculectomy with cataract surgery. In this case, I gave the triangular flap. After doing the CCC, I just removed the lens with the tumbling method. I had to take care of the geniole while removing the lens. After doing the peripheral iodectomy, I just gave one sutures in the apex of the triangular flap. This is the postoperative picture, the 612 vision and 12 millimeter of mercury intraocular pressure. So pseudoexfoliation syndrome is an age-related systemic condition that is characterized by an abnormal accumulation of deposition of extracellular matrix materials throughout the anterior segment of the eye, most notably along the pupillary border and on the lens capsule. This is one of the most common identifiable secondary open-angle glaucoma, and it's common in the Scandinavian countries. LOX1 gene is responsible. The pathogenesis is the pseudoexfoliation materials entrapped within the trabecular meshwork pore that causes resistance to outflow. The prognosis is really very worse because it has a high tendencies of intraocular pressure, and the progression is more, and progression of visual field and also optic nerve cupping is more comparison to the primary open-angle glaucoma. We can start with the medical management in early case. For this, as the progression is very much rapid, so immediate and appropriate treatment is very much important after diagnosis. Prostaglandin analog has a role, but in some studies shows that it causes relatively some inflammation. Beta blocker has a good role in case of middle income people. Carbonic anhydrase inhibitor has a great role, and also where the one medication doesn't work, in that case combination medications works good. Surgical options have many, like laser trabeculoplasty, filtration surgery, and tube shunt implantation. We can do the selective laser trabeculoplasty and argon laser trabeculoplasty, but selective laser trabeculoplasty is better. And average the 6 to 7 millimeter of mercury intraocular pressure can be reduced after trabeculoplasty. But in the cataract with high pressure, trabeculoplasty doesn't have any good result. This is a case of advanced pseudoexfoliation glaucoma with mature cataract with a little subluxation. In that cases, I didn't do the phaco surgery. I did the manual small incision cataract surgery, as the anterior chamber is very much shallow. After doing a very good CCC, I had to remove the nucleus in a very cautious way, as the nucleus is very much hard, and I had to take care of the geniole. And the geniole was very much weak, almost 100 degree. In that cases, I put CTR ring. After putting the CTR ring, I stabilized the lens bag, and then I put the intraocular lens. So postoperatively, the patient was doing good. This is another case where there is a early pseudoexfoliation glaucoma, but advanced visual field defect. In that cases, I did combined surgery, phacotrabeculectomy. In that cases, I had to take care of the geniole, I had to take care of the endothelium. Same method, I did the single suture trabeculectomy, triangular flap, and the postoperatively patient was doing really very great with controlled intraocular pressure. Trabeculectomy. Glaucoma surgery is generally undertaken when glaucomatous progression occurs or intraocular pressure is elevated to a level that progression is likely despite maximum medical therapy. A 20 years follow-up study shows that pseudoexfoliation glaucoma cases that failure rate of trabeculectomy is more in comparison to the primary open-angle glaucoma. And pseudoexfoliation, those patients have a pseudoexfoliation, they have a tendency to develop more cataract. So in that cases, combined cataract and glaucoma surgery is needed. If we do the cataract surgery alone, we can do where the glaucometer changes are minimum. In that cases, average intraocular pressure reduction is 2 mm of mercury. But combined versus cataract surgery alone, if we do the only cataract surgery, in that case, only 1 to 2 mm of intraocular pressure reduction occurs. But if we do the combined surgery, in that case, 4 to 6 mm of mercury intraocular pressure is reduced. So the combined cataract and trabeculectomy surgery has a greater role in case of pseudoexfoliation glaucoma with cataract. But we can do the combined, but in a separate time. In that case, failure of trabeculectomy is more. We can do the express implant. Different studies suggested that the express implant also does a good. The advantage is it may reduce inflammation due to decreased tissue manipulation. But average, no difference between the express implant and trabeculectomy. Trab versus tube implant. In the trab versus tube study, for the 5 years study was done, intraocular pressure reduction is almost similar in the tube, especially in the Barwelt implant compared to the trab only. But failure rate is significantly higher in the trab group. We can do the angle-based procedure like trabectomy surgery and also viscocannalostomy. And a postoperative consideration. Usually in case of pseudoexfoliation glaucoma, there is some aqueous flare and fibrinoid reaction and posterior synechiae can be occurred. In that cases, the pseudoexfoliation patient, we have to give aggressive steroid to reduce the inflammation. Early postoperative IOP spike is more in case of pseudoexfoliation glaucoma. In that case, we have to take care of intraocular pressure too. And very interesting, intraocular pressure elevation more than 30 mm of mercury. This is more common in the phacoemulsification alone, rather combined surgery, where the 8.3% have a intraocular pressure more than 30 mm of mercury. We have a lot of challenges like rigid pupil, hard nucleus, zonular weakness, high intraocular pressure, advanced optic nerve damage, postoperative IOP spike, and postoperative inflammation. So what is my take-home message is, pseudoexfoliation glaucoma with no cataract with high pressure, we can start with the medical treatment, then laser, then trabeculectomy. If the medical treatment and laser failed, pseudoexfoliation glaucoma with cataract with high pressure, we have to control the intraocular pressure even with hyperosmotic agent, then we can do the combined surgery. But most important thing is take care of the increased incidence of postoperative complications like inflammation and also trabeculectomy failure later on. Thank you so much. Thank you for the patient hearing.